Welcome to NCPDP Unscripted, the podcast where healthcare meets real talk. Each episode, we will dive into unscripted conversations with industry leaders, changemakers, and innovators discussing the challenges, breakthroughs, and behind-the-scenes stories you won't hear anywhere else.
All right. Well, we are recording here live at our NCPDP Annual Conference, and very excited to have Secretary Azar, you were Health and Human Services Secretary from, if I get this right, 2018 to 2021, correct?
That's right. Yep.
Well, welcome.
Last 3 years of the first Trump administration.
Okay, fantastic. Well, welcome to the NCPDP Unscripted podcast.
Thank you.
So you just finished your keynote address to our attendees. Really well received. Appreciate it. Thank you so much. You talked a lot about just all the policies that you put in place while you were secretary, and I want to kind of start there. You did a lot with drug pricing, obviously COVID. Just talk a little bit about kind of the where the policies were and what you put in place during your term.
Yeah, so we talked this morning in the keynote a lot about the value-based transformation of healthcare, because that's something that really has been, in a very bipartisan way, the future direction of healthcare since Secretary Mike Leavitt got us initiated on that back in 2005 when I was his deputy secretary. And that's been carried forward, and I really tried to give it the final emphatic push when I was secretary around 4 domains, and 2 of them we did a deep dive with the group here on because of, I think, very central importance to the work of the NCPDP. So the 4 domains were price and quality transparency, so absolutely vital, of course, to the work. Then the second was enabling integrative collaborative care among providers. The third is interoperable health information technology with personal ownership and portability of that health record. And the fourth is paying for value instead of paying for procedures. So we went through some deep dives on a couple of those areas, all of which are themes that continue. They continued after me under Biden, and I will continue under the current team with their own areas of emphasis and focus that are different, but still, I think, central building blocks to a value-based transformation of healthcare.
Yeah, absolutely. And, we talk a lot about price transparency. So obviously, going to the pharmacy counter and finding out how much you're going to pay when you reach there, we see a lot of abandonment there.
Well, and your tools and standards will be absolutely vital to that information flow, especially as by 2028, we'll be implementing the PBM, the Pharmacy Benefit Manager reforms, that were in the One Big Beautiful Bill. I believe that's where they were. And that's going to require a real rewiring of the data flows so that the kind of transparent information that's required out of that statute does get to employers and others.
Right, yeah. And I loved the question that was asked about how do we get pharmacists paid, because I do think that CMMI, so the Centers for Medicaid and Medicare Innovation, is putting some kind of model in, right? Because I think what we've seen, obviously, after COVID was really the role that pharmacists can play in clinical services. Yep. And I think trying to figure out how to get that reimbursement. So can you talk a little bit about that, kind of your thoughts around the CMMI model?
Yeah, so during COVID, America's pharmacists and their technicians were absolutely vital to our ability to get through that. And I was able to use the emergency authorities that I had under the Public Health Emergency and under the National Emergencies Act to pay pharmacists for vaccination, for doing testing, and the techs even. I was able to have techs do vaccination. But that authority was an emergency authority. And the challenge we have is to add a new provider group, or a benefit. So say getting dental covered by Medicare requires Congress to act. Getting pharmacists paid, I think, would require Congress to act to create them as a provider group. So the alternative is we have the Center for Medicare and Medicaid Innovation, which has a ton of money and is able to try new methods of payment in the Medicare system to save money and improve care for our beneficiaries, especially as we have the primary care access crisis and our rural health care crisis, where we simply don't have enough providers. I think there should be a lot of desire to try experiments that would enable us to reimburse pharmacists to practice at the top of their license. I mean, I don't think people often will walk into a pharmacy and they see the pharmacist behind the counter sort of moving pills and putting them in bottles.
Right,
And
right.
they don't see the years of intense, in-depth, extensive physiology, medical training that has gone into the doctor of pharmacy that person has. And so we should be leveraging that. You know, I ran the Indian Health Service as part of HHS.
Okay.
So we had to deal with care not in rural America, but remote America. And we had to leverage even people that had high school degrees in remote islands and remote villages to deliver health care. We called them our community health aides. And what we did was we would have a manual of standing orders that were approved by physicians that then our community health aides, these high school educated individuals, could actually execute against, and also through telemedicine over video and phone, deliver care under the direction of a physician. I'm not saying that's the exact model for how one would work with pharmacists, but I'm just saying we can, when we want to, figure out ways to leverage capability and be more flexible than we are in our system to solve these gaps in care that we have. And we absolutely have a primary care and rural care gap.
Yeah, I love that, and that's something that NCPDP we're trying to support as well. I think there's a lot of push to figure out, you know, as pharmacists start to do more clinical services, what are the kind of unique ways we can do that. So that's great to hear. Obviously, interoperability, you talked a lot about patients getting their own records. I think that's also a really important kind of area to be focused on. It's great to hear that, you know, it has been transcending, I think, across administrations. You know, what are you thinking about? I know you're now in the private sector. What do you hear out there about kind of what's happening with policy, and are we moving in the right direction? And
Well, I think we're definitely moving in the right direction, and I think that I think we don't appreciate how far we have advanced with interoperability, with portability. Do we have more room to grow? Absolutely, and I think this administration is very committed. So the leadership of CMS, Dr. Oz, Chris Klomp, who runs Medicare, these are people who all have a deep technical understanding of healthcare, and you know, Amy. So just the whole crew.
right, yeah.
Amy Gleason,
Yeah.
the whole crew are people that bring a lot of private sector experience and expertise to the table around health IT, and I think we'll see continued real pushing there. One of the things, though, that the theme that I tried to talk about in the keynote was, listen, we have under President Obama and the High Tech Act, we paid people to adopt health IT.
Right.
So we paid people to take their medical records on paper and shove them into a computer, but we didn't actually make them interoperable or make them communicate. Under 21st Century Cures, we've been mandating interoperability. I think that that's a push. There's a pull through value-based care. So if I'm a physician group or a healthcare system that owns risk of providing total cost of care to a patient, so that I'm on the hook if that patient ends up being admitted to the hospital. I'm on the hook if there's a medical error. I'm on the hook if they're not getting their HbA1c levels down and have a complication. I'm on the hook if they have CKD progression because they're not taking their SGLT2, et cetera. I need a deeply comprehensive data system and data archive about those patients, because I need to be able to figure out which patients I need to devote most of my energy to, which ones I don't have to have as many points of contact with, and also with AI, this is where AI enablement with the EHR. If we get real-time data flows into them, if we get real interoperability and real portability, I'm going to be able to see who's about to crash.
Right.
Who do I have that's about to crash into dialysis, for instance?
Yeah.
Who do I have who's about to have an MI? Who's having a hypertensive event? Whatever else. Those data systems will enable that and are critical to that. And that gets our providers demanding the interoperability instead of being compliant with that.
Right, exactly. And I love the example that you used in that same kind of value-based care model of, you know, SDOH, right? Does someone need a ramp? Does someone need food? And I feel like in what we see in the pharmacist side is a lot of our community pharmacists know that information.
Right.
I know talking to one of the community pharmacists who said, you know, someone didn't have heat in their home, and we delivered firewood to them. So, you know, you've got the data piece, and you have the, you know, also just the what else can we do?
Well, for many Americans, the pharmacist is the patient-centered medical home for them.
Yeah.
And if you think about it, especially if you have any chronic health conditions, you are interacting with the pharmacist much more than you are with your hospital or your physician. That's your most common point of contact. In part, that's actually why I think we have so much hostility often around the issue of drug prices.
Yeah.
because of the weird way that we designed our insurance benefits. Drug benefit came later, and by the time drug benefits came along, for reasons I can't quite explain, the cost sharing was basically double what the cost sharing is. What you pay out of pocket is double what you pay when you go to the hospital or the doctor on the drug benefit design that was stapled on decades later. I've never quite understood that, though, because you have literally a situation where the doctor, the insurance company, and the patient all agree the patient should be on that medicine.
Right.
We use cost sharing and deductibles as a way to deter you from behavior. We should be doing everything in our power to cause adherence and uptake. I don't get that. But back to the story. Because you're taking meds, you're interacting with the pharmacist constantly. That's your face.
Yeah.
And that's someone who's going to be able to know, like you said, are you suffering from a social determinant of health that's impacting your health care? Are you facing something that maybe is going to crash on you, that maybe if you could have better integration with pharmacists and the care teams around them, alerts and through the EMRs, that kind of integration.
Yeah.
I mean, there's so much potential, I think, if we can start envisioning pharmacy as much bigger than dispensing pills.
Yeah, absolutely. Well, as we wrap up, I know you had a great kind of closing, sometimes you just feel like it's doom and gloom, right?
Yes.
We've been doing this for decades. I know I've been doing it for a couple of decades.
Yeah.
Would love to just kind of hear your thoughts on what we should be hopeful for.
Yeah, with our healthcare system, any healthcare system, anyone that promises utopianism in a healthcare system, you should kick them out of the room, because the simple fact of the matter is, in any healthcare system, healthcare goods, healthcare services, they're economic goods. Economic goods follow economic laws, and one economic law is a law that there's not an infinite supply of everything. Mm-hmm. And so you're never going to be able to have sort of a utopian world of everything is free and everyone gets everything, and that's not realistic, unfortunately. But what does get me so excited is I think that we're at one of the great revolutions in the history of humankind in health. I think it is on the order of clean water, sewage, clean sewage, and antibiotics and vaccines. And that is about 26 years ago, thanks to the great work of NIH, Dr. Francis Collins, and others, we decoded the human genome. Mm-hmm. And over the last couple of decades, we have dramatically enhanced our genetic and molecular understanding of the nature of disease. Back when I first joined the drug industry in 2007, we were still innovating largely by having molecules in a data bank and just testing them to see what might work.
Right.
Now we are understanding the mechanism of action of a disease. We are understanding what we can do, like there might be a receptor on the cell that we can block that will prevent the action that we're trying to prevent. We can custom design medicine to do that. And then when we go into clinical trials with people, we pretty well know that it's going to work. We just don't know. Maybe there's some other safety or efficacy effect because of the true complexity of the human physiology, but that's what we're often testing. So we've dramatically increased, I believe, the probability of technical success of our drug programs. That can reduce the cost of development. But we've also gotten to where we now so deeply understand disease that we can literally turn diseases off. We can turn cancers off. Not all, but we can turn cancers off.
Right.
I told the story in there of a young man when I was secretary. I went to Children's Hospital. He had come, 19-year-old young man, came in the hospital, sickle cell anemia. He was going to have a life of pain and agony, a shortened life, would cost the system millions of dollars. 30 days later, he walked out through gene therapy without a single sickle in his blood. God willing, that'll be permanent. He'll live a happy, long life. And it'll save the system, probably $10 million, but the therapy costs $1 million. So we have to figure out how to deal with that. Yeah. But that potential is there, and I think over the next couple of decades, we're going to reconceive our expectations of what it means to get disease and whether we have to live with it or cure it. And God willing, we even get to the point where this understanding allows us to now prevent disease instead of even treating it.
Yeah.
That's the next thing to get to.
Yeah.
But bottom line, I think we're at a golden age of biopharmaceuticals, and as a result, a golden age for healthcare, as long as we don't stifle it.
Yes, that's wonderful. Well, Alex, thank you so much for joining me today, and thank you again for a wonderful keynote. And we look forward to kind of following what you're doing now out in industry.
My
so
pleasure.
Thanks so much.
Good to be with you.
That's a wrap on this episode of NCPDP Unscripted. Thanks for joining us as we explore the voices and ideas driving innovation in healthcare. If you'd like to be a guest on the show or have topic ideas you'd love to hear us cover, we want to hear from you. Until next time, stay curious, stay connected, and stay unscripted. Our podcast is proudly sponsored by Marks Productions.